what, 19th, 2022. And we're going to be performing a Deuk laser disc repair at 3 discs lumbar today. Our patient has 3 herniated discs, L2-3, L3-4, L4-5, and he is having right leg pain, weakness, and atrophy. He's losing his muscles because the nerves are being crushed at these 3 levels. His L5-S1 disc is fine, but the L2, 3, 3, 4, 4, 5 is where the problem is. So I've already placed the first spinal needle. We've gone transforaminal, and we're inside the disc. All right, so we're going to place our second needle, but before I do that, I make an incision. Let's give some more numbing medicine. Yes, sir. Under the skin. That's probably enough. So I'm giving our patient a little skin numbing medicine. Just to, it actually has epinephrine in it, so it stops bleeding under the skin, but it also, it also numbs up the skin so he doesn't feel so much pain. It makes my anesthesiologist happy. So I cut right along the needle shaft where it enters the skin. You're okay. So he's a little light, and we may want to give him a little more num-num. More? Yep. So we're going to give him a little more numbing medicine on the skin to make him comfortable. Now, how long has he had his symptoms? Do you guys remember?
2 months.
2 months. So he's noticed his atrophy and weakness for the last 2 months. So he has an acute radiculopathy. I'm going to give him a little bit more numbing medicine to make him feel better. Most of it's coming out, but there we go. You're okay. I'm just giving you some numbing medicine. Patient needs to be awake at the beginning of surgery to help me, because if I accidentally get too close to the nerve root, I need him to tell me that. And the best detector of being too close to the nerve root is the patient. They will say, oh, I have pain going down my leg. And that means I have to change my course and go to a different place. Shot. I feel the facet. It's perfect. I'm underneath the nerve root. Shot. I can feel the herniation right now. Shot. Yep. So 2 down, 1 more to go. We're going to be able to do all 3 discs with 1 incision, 7 millimeters. So why do people need this surgery? They need the surgery for a variety of reasons. One of them is back pain. Another one is pinched nerves or irritated nerves. Shot? This particular patient needs the surgery done because he has pinched nerves. Shot? I may have to make a second incision. Shot? If I can't reach this, I'll have to do a second incision. Shot? Now these are special needles, shot. They actually have a tapered beveled edge or tip that allows me to direct the needle to where I want it to go by aiming it properly. And that's what I'm using. I'm using that feature. Shot. Are you okay? Shot. Are you okay?
How you doing, Joe?
Shot. All right, let's get an AP, see where we are. So I'm going to use 2 views of the X-ray. I'm going to use the side view and I'm going to use the front back view to guide the needle. You have to use 2 views, folks. Yeah, see, that's why. We're way off. We're out by the transverse process. That's why you have to use 2 views. You cannot rely on 1. Otherwise, you'll make a mistake. So the bone that I'm feeling is the TP. And I actually may have to do a second incision. Let me just see if I can get this done with this 1 incision. Shot? He's very thin. Sean? Sean? I feel the facet, I think. Yep. Let's get an AP and just verify that that's the facet joint. What I like to do for my technique in the lumbar is I dock the facet, then I slip around the facet, just redirecting the needle a little anterior. There we go. Much better. All right. Again, it's a little bit of a reach to get up there. Let's see what happens. I'm going to try, and that way our patient doesn't have to have a second incision. But if I can't do the surgery safely through this one incision, I will make a second incision higher up. Shot? All right, why don't we show our audience, Shot, why people with a herniated disc get back pain. Let's run our video showing why herniated disc, Shot, cause back pain.
Traumatic injury to the disc can cause annular tears to form. Pressure on the disc causes herniation of the nucleus pulpus through the annular tear. Inflammatory tissues develop within the annular tear, causing back pain. The inflamed annular tear generates pain signals. Additional injuries can cause symptoms to worsen. Inflammation from the annular tear can spread to nearby nerve roots, causing leg pain. Signals travel up nerves to the brain, causing localized back pain. Pain signals reach the primary somatosensory cortex, causing conscious awareness of pain. If you have a herniated or bulging disc and back pain, submit your MRI for a free review at www.mri.deukspine.com.
All right, let's go to the x-ray. Jordan is showing you the pedicle. Outline the pedicle. It's a big circle. And that's a piece of bone. We want to be, the disc really starts at the mid-pedicular line. Show the pedicle above. There you go. Show it, circle the pedicle above. Okay, and now draw a line from the mid-pedicle to the mid-pedicle. Mid-pedicle down to the next one. Mid-pedicle, that's where the disc is, okay? So you want to aim for that, and you know you're entering the disc at that point. And it's a rough estimate. Okay, let's go lateral shot. All right, so that looks good. Shot, I feel the herniation. Shot. Okay, you can see the bevel tip of the needle. It's directional. Shot. So I'm trying to slip in to the disc right above the end plate of L3. This is the 2-3 disc. So the bone at the bottom is 3 and the bone at the top is 2. So we're in. All right, this is the transforaminal approach. We're going to have to do 2 incisions, which is fine. I need my patient awake.
Hey, Joe. Joe is awake. Eyes are opening.
Okay, let's not use names. Are you awake? Can you hear me? Sorry to wake you up. We need your help for just a minute, okay? Now, our patient's primary reason for having the surgery is to unpinch the nerve, but a lot of people have pain from a herniated disc. So I'm going to draw these out. Is there any way to show the view from the camera?
Yeah, we see it.
Well, I want to show it in the operating room so all of our observers here can see it.
Oh.
Are you awake?
He said yes.
All right, perfect. So we know that this disc is the L2-3. This is L3-4. And this disc is the L4-5. These are where our patient has herniations. Are you having any pain? can see him arching his back. How bad is that on a scale of 1 to 10? Shot? Let's transfer it to the x-ray image, please. Perfect. How bad is that on a scale of 1 to 10? 10. Is that where you get your back pain? All right, Jordan, let's stay on the x-ray. Jordan, show the audience where the tear is. You see the tear right there? So we injected the black dye into the center of the disc, and it's leaking out through a tear in the back of the disc. Now it's also going out through the front. Show them the tear in the front. But the front tears never cause back pain. That's because they have a different kind of nerves there that people can't really feel. So that was a 10 out of 10. He had 10 out of 10. That's horrible. It's the worst pain in the world. 10 out of 10. And it's concordant. Concordant means it's his typical pain he gets every day. All right? So we nailed it. We nailed one of the discs. Now, he's not here for back pain. He wants his back pain gone, but he's really here for his leg because he's losing muscle in his leg. He's concerned that their nerves are pinched. Are you comfortable?
Yes, he is.
All right, he's comfortable. Again, you can see him arch his back. How bad is that on a scale of 1 to 10? How bad is that? How high did it go? How high did it go? What's the highest it went?
5. Just give me a 5.
All right. I don't think that's accurate. Okay. Can you hear me?
He said yes. One more.
All right. We need to know from 1 to 10, 10 being the worst pain in your life, how bad it went when I did this.
7.
7. Okay. Very good. That's the highest was a 7. Is that where you typically get back pain?
Yes.
Perfect. 7 over 10. So the L3-4 disc is 7 over 10. Jordan, show the audience where the tear is in the back of 3-4. And you can actually see the dye leaking out into the epidural space around the nerve roots. Now just, Jordan, this is interesting. Yeah, right there. Show the audience the herniation. You can see the herniation. So it's a negative image, meaning it doesn't have the dye. But that's the next herniation. And it's pretty substantial. All right. Are you feeling better? I think, okay. Yeah, let's just do it. He's taken a lot. All right. Any pain in your back? Now check it out. He's a true American. Red, white, and blue right there. Okay? He bleeds red, white, and blue. Are you okay? All right. How bad is that on a scale of 1 to 10?
Huh?
What's the highest it went? 10. So he had 10 out of 10 pain at L2-3. Folks, we've just confirmed that those 3 discs are the cause of his back pain with a discogram. And it's the most sensitive test in the world for confirming that the disc is the cause of someone's back pain. All right, we're going to get started. We're going to start with which disc, Luis? Well, we don't do 5-1. 4-5. All right, so we're starting with L4-5. I'm going to put a guide wire in. And now we have a guide wire, and it's going to guide the dilator. Let's get an x-ray. Are you pulsing? Yes, all right, show them the guide wire inside the disc. See the guide wire, the tip of it there? You never want to go past the front of the disc. You could perforate the bowel. All right, so we're going to leave the guide wire, and we're going to pull the needle out. Okay, so I got the needle out, and now we're going to, can you see this, Henry?
Yeah.
We're going to take this, it looks like a metal pencil, and it's got a hole in it, and we're literally going to run this down the guide wire. Now, normally you would never stick something like this in someone's body because you could hurt something. But because we have a guide wire, we know the pathway that this will take is safe. Because I did the hard part in the beginning when he was awake. All right, let's see how he does. I can give some numbing medicine. Let's give some num-num. All right, any questions from our audience? That's too big of a needle, I think.
No current questions.
All right, why don't we run the video showing them how the Deuk laser disc repair actually works. Like, what does it do?
Disc herniations are a common cause of chronic back pain. The inflamed annular tear causes back pain. Inflammation of the nerve roots causes leg pain. A Band-Aid-sized skin incision is made. A small tube is inserted without damaging the bone or soft tissues. The laser removes the herniation and debrides the annular tear. The annular tear heals on its own. If you have a herniated or bulging disc and back pain, submit your MRI for a free review at www.mri.deukspine.com.
All right, folks, hope you've learned something from the video, how the Deuk laser disc repair works by cleaning out the herniation stuck in the annular tear, cleaning out the tear so it'll heal. We're going to do the entire surgery through this tube. This tube is 7 millimeters wide. Now I got to place the tube over the dilator and bring the tube down into the disc right through the tear, right where the herniation came out. Now for lower back, we go on the side of leg symptoms. For the neck, we go opposite of the side of arm symptoms. You can see the tip of the tube is in the disc. That should be good. And now we take the dilator out, and what we're left with is basically a passageway into the disc so I could repair the disc without opening the patient's back up. This is true endoscopic spine surgery. All right, if you have questions, folks, feel free to ask me. I like to answer questions during surgery. Otherwise, surgery gets a bit boring because it's so straightforward. Sometimes Dr. Berndes will make it exciting for me. He'll keep the patient awake a little bit so they move around and I have a moving target. Thank you, Dr. Berndes. I'm just kidding. This patient is doing fantastic. He's stable. He's not moving at all. He's doing great. He's comfortable. And basically, we're going to go down the tube at this point with the scope. Arias, you can see this is the light source. And it basically sends the light to the end of the tube so I could see what's down there. See that? All right, this is inside the herniation right here. I'm going to reach my grabber down. I'm going to pull out any pieces of herniation I can get. And then I'm going to bring the laser in because the laser is really the best tool. You can see the grabber doesn't fix the tear. The laser will fix the tear. All right, if you have questions, feel free to type them up. We're going to get started. It should be at 30, right? We're at 30? Good. All right. By the way, our laser fiber is a 1 millimeter thick. So that glass tube you're seeing is 1 millimeter. That's how small it is, very precise. People ask me, are you worried about damaging things with the laser? The energy only comes out 0.5 millimeter from the tip. So it's only what the tip touches. And the reason for that is because we're inside water. If this laser was shooting across the room, it could actually go across the room and hurt somebody. But because it's in liquid, the water dissipates the laser energy. It actually turns to heat, but there's cold water. We use refrigerated saline. It's all sterile. All right, the blue stuff is the herniation. That's what we're trying to get rid of. And the white thing is the annular tear. We want to clean that up as well.
We have a couple questions.
All right, feel free to ask questions, folks. I'm happy to try to answer them for you. Go ahead.
The first one comes from Jim Kitterman on Facebook.
Hello, Jim. Thanks for joining us this morning.
And he asked, has any insurance agreed to pay for the surgery yet?
So Jim is asking, has any insurance agreed to pay for the Deuk laser disc repair? Absolutely, Jim. We were just looking at that yesterday. We've had over 60 claims paid by a variety of insurances, including United Healthcare, Blue Cross, Cigna, work comp, auto accident insurance like State Farm and things like that. And the average payment actually is around $70,000 per surgery. So the problem is, Jim, whether they're going to pay. I mean, it's not that they pay once in a while. The problem is they don't pay consistently. Okay? They don't pay consistently. So when you don't have consistent payment, you don't have predictability. And the problem is that our surgery center, you know, we have predictable expenses, like Luis's salary, for example. You know, I got to pay Luis. I'm just kidding. But no, seriously, we have very high expenses, and those expenses, they're not dependent on whether we get paid from the insurance company. So we have to have our costs covered, which is why we ask patients to pay a deposit out of pocket, just like you would for any surgery. You're going to have an out-of-pocket expense, unless you're work comp, or unless you have the best insurance in the world that doesn't make you pay anything. I've had a couple of patients like that, but they pay premium for their insurance. But generally, insurances require you to pay out of pocket. All right, I want you to look, see right there, see the pink stuff? That is where all the pain comes from. That pink stuff is called granulation tissue. That's inflammatory tissue. And that's where the little nerve fibers are that cause so much pain. So we want to make sure we zap it away. Great question. I hope I answered it appropriately for you. So the answer is yes, we're getting some insurances to pay, but not consistently. And we'll still fight for them to pay, but that process can take 3 to 5 years. And we can't wait 3 to 5 years to pay our bills. So there has to be some money coming in from patients, and that's called a deposit that we accept up front, and then we go after the insurance. A lot of granulation tissue. You can see all the pink stuff. The pink represents blood vessels in capillaries, little capillaries. It's a sign of chronic inflammation. All right, what other questions do we have?
All right, these next two questions come from Robert Dunn on YouTube.
Hello, Robert. Thanks for joining us on YouTube.
His first question is there any risk of damaging the nerves when performing the surgery?
So, is there more than one question or just one?
Yeah, that one, and then the second question was, do you see international patients?
Yeah. So first of all, is there any risk of damaging the nerves when I do the surgery, when the surgery is done? So it's really an interesting answer. First of all, is there a risk of me damaging the nerve? Yes, but it's very low. I've never damaged a nerve, ever. And I've done over 1,500, and I have done an average of 2.5 discs. So that's 2.5 nerves that I go past for every surgery. So I've really gotten past 1,500 times 2.5. So let's just say around 4,000 nerves, and I've never damaged one of them. Now, is there a risk if somebody else does it that doesn't know what they're doing and they're not trained properly? The risk goes up dramatically. So in 1,500 surgeries, I've never damaged a nerve, but other surgeons damage nerves all the time, and I wouldn't trust anyone else to do the surgery. People always ask me, am I the one who does the surgery? The answer is yes. There's only one other person I would trust to do this surgery, and that is, that's my son, Arias, when he becomes a doctor someday. He's like me. He's very detail-oriented. My brother is also a neurosurgeon, but I would not trust him. I'm just being honest. So it's not about just the procedure, folks. It's about who does it, you know? And a lot of surgeons are not very good. I wouldn't trust them on me. As far as whether we take international patients, absolutely. We have patients from all over the world. They come here for the surgery. It's 3 days. You come to the office on Monday, you have surgery Tuesday, and then you can go home on Wednesday. Unless you want to spend some time with Mickey Mouse. at Disney, which is just an hour away from us. All right, so far everything is going well. You can see the blue stuff, the herniation. I'm breaking it up into little pieces with the laser and getting rid of it. And we're almost done getting rid of the herniation. Now the white stuff is the annulus right there. That's a torn annulus fibrosis. And it's very swollen and it's starting to scar up. So I'm going to remove some of it to debulk this herniation because I don't want him to have any nerve pressure when I'm done. His biggest concern is not his back pain, it's his leg weakness. So I want to make sure I take care of his concern. Too many doctors don't pay attention to what the patients want, and they do what they want, unfortunately. But medicine has to become more patient-centric rather than physician-centric. So we listen to our patients and their complaints, and we try to fix them with the surgeries we do. All right, there's a blood vessel right there, a little vein. Everything okay? Oh, fine. You had me worried. You came charging in the room like a rhino. That's all right. All right, you can still see parts of the tear down here. This is the innermost part of the tear. And I'm just cleaning out the herniation from the tear. Any other questions, Henry?
No current questions.
All right, let's show our audience the video comparing the Deuk laser disc repair to a fusion. Just about done here. And we're going to wrap it up. There's some bone right there. That's why it's sparking, because calcium, the laser, when it hits bone, it sparks a little bit. It's not really a spark, but it's a flash. There's a blood vessel right there, a little vein. And we're pretty much almost done here.
Deuk laser disc repair, a comparison with traditional spinal fusion surgery. A patient with chronic back or neck pain originating from a symptomatic disc injury could undergo either traditional spinal fusion or less invasive Deuk laser disc repair. This MRI represents a typical case with L4-5 and L5-S1 symptomatic discs. A symptomatic disc causing neck or back pain can include bulging discs, herniated discs, ruptured discs, degenerative discs, protruding discs, spinal stenosis, radiculopathy, and sciatica. This patient can choose traditional fusion surgery or the Deuk laser disc repair to help alleviate the pain caused by and within the symptomatic discs. Here, two patients with comparable disc injuries are treated. On the left, the highly invasive spinal fusion, and on the right, the least invasive Deuk laser disc repair. The spinal fusion requires a very large incision, usually leaving a large scar. The Deuk laser disc repair requires only a very small incision, usually less than a half an inch long. In this small opening, a cylindrical rod, called a dilator, is inserted to gently spread the muscle to create a small passage and guide through which the surgery is performed endoscopically. The incision for the fusion continues, including penetrating the skin, fat tissue, and multiple layers of muscle through to the bone. With the Deuk laser disc repair, a mallet is used to advance the tip of the dilator into the symptomatic disc. A tube, called the tubular retractor, slides over the dilator and is carefully positioned into the disc, again using the mallet. The rest of the entire Deuk laser disc repair surgery will occur inside this narrow tube. To access the spine, the spinal fusion requires the muscle to be separated from the vertebrae. This very invasive action causes trauma and permanent damage to the muscles. Whereas in the endoscopic Deuk laser disc repair, the muscle is not damaged. The endoscope camera is inserted into the tubular retractor to allow the surgeon to guide the laser inside each symptomatic disc. To accommodate the fusion hardware, a large bone grabber is used to perform a laminectomy by removing bone from the spine. The fiber optic laser used in the Deuk laser disc repair is manipulated with great accuracy to remove only painful inflammatory tissue from the disc. In this highly magnified view, the laser is used to precisely remove damaged disc material that is causing the pain. The laser is debriding, or essentially vaporizing, damaged tissue in the disc's outer layer, or annulus, specifically at the annular tear, the source of the rupture or herniation and pain. After the fusion patient's damaged discs are removed, a metal or plastic cage housing bone grafting material is inserted in place of the removed discs. Once the laser has removed the painful part of the annular tear, the endoscope and tubular retractor are removed, leaving less than 1/2 inch incision in the skin, which is closed with a single stitch, Steri-Strips, and a Band-Aid. Total time for the Deuk laser disc repair surgery, approximately 1 hour. The fusion, however, is still underway. Holes in the spine must be tapped in preparation for the large pedicle screws that anchor the fusion hardware. The Deuk laser disc repair patient is in recovery usually 45 to 60 minutes before release to go home. The fusion screws are inserted into the bone, as shown in the X-ray. After all screws are in place, rods are used to connect the screws together to prevent movement of the secured vertebrae. Cross-links are added to bridge the rods together for additional stability. Fusion hardware, by design, is to fuse joints that normally move, preventing natural movement in the damaged portion of the spine. Whereas with the Deuk laser disc repair, there is no loss of movement. Normal movement and flexibility of the disc and joints is preserved. The Deuk laser disc repair patient is soon back home, enjoying life, with a very fast recovery, allowing normal activities without pain. Meanwhile, bone graft material is placed throughout the fusion surgery site. These morselized pieces of bone will eventually grow together to help promote the fusion process. Prior to closing the wound, a temporary drain is installed to allow excess fluid to drain. Average surgery time of a traditional 2-level fusion is 2.5 hours, with an additional 3 to 4 hours in the recovery room. As we've seen, in comparison, a spinal fusion requires a much larger incision and results in a significant amount of scar tissue. The Deuk laser disc repair's 1/2 inch incision leaves no scar tissue around the spine or nerves. A large amount of bone is removed with a spinal fusion. With the Deuk laser disc repair, no bone is removed. Each disc is accessed through a natural opening in the spine. The entire disc is completely removed in a spinal fusion, even though only 5% may be damaged. The Deuk laser disc repair leaves the normal parts of the disc in place and removes only the painful annular tear on the damaged disc. Fusion requires hardware, including screws, rods, plates, etc. The Deuk laser disc repair does not require any hardware. The patient is totally hardware-free. Fusion surgery is very invasive. Cutting and moving the muscle structures and tissues for a spinal fusion causes trauma, resulting in permanent damage to the muscles. Whereas with the Deuk laser disc repair, there is no damage to the muscles. The Deuk laser disc repair is the least invasive surgery available to repair a damaged disc. With spinal fusions, patients are required to take highly addictive narcotic painkillers, which can cause constipation, bowel, and bladder complications. Due to the minimal pain, narcotics are not needed with the Deuk laser disc repair. Spinal fusions have a high risk for infection. The Deuk laser disc repair has a very low risk for infection. In the 7 years the Deuk laser disc repair has been performed, there have been no infections. Spinal fusion surgery has a very long recovery and requires a great deal of physical therapy and time to heal from the trauma in the muscles and the spine itself. Whereas the recovery from Deuk laser disc repair is in a matter of hours or days, rather than weeks or months. With fusion, the spine is being fused together, losing movement. Whereas there is no fusion with the Deuk laser disc repair. Normal movements of the joints in the spine is preserved. Spinal fusion results in loss of mobility. There is no mobility loss with the Deuk laser disc repair. In fact, most Deuk laser disc repair patients experience improved mobility after the surgery. The Deuk laser disc repair is FDA approved. All the instruments and equipment used are FDA approved. This proprietary surgery itself has been peer-reviewed and published and is performed exclusively at the Deuk Spine Institute. With the highest published success rate of 95%, the Deuk laser disc repair is proven to be the most successful and least damaging spinal surgery in the world for the treatment of symptomatic damaged discs causing back pain, neck pain, sciatica, and radiculopathy due to herniated, degenerated, or bulging discs.
All right, welcome back. I got it. I'm glad you could see a comparison of open back surgery with fusion versus the Deuk laser disc repair. It gives you an idea of just how invasive and traumatic open surgery is. And by the way, when I do those fusions, it's a lot less traumatic than most surgeons. They take 12 hours, 14 hours to do surgeries like that. We usually get them done quicker. All right, we're going in now at the 3-4 disc. And as I said to you before, I could not get into all 3 discs that we have to do today with one incision. So we will be making another incision shot soon at L2-3 for the last one. So the patient will have 2 7mm quarter-inch incisions, basically. The whole surgery is done endoscopically. And by the way, if you have an opportunity, go to the App Store. You can download the Deuk Spine Institute app. It's free, and it's got great information about spine conditions. All right, that should be good.
We have a question.
We will take the question.
This comes from Trevor on YouTube.
Hello, Trevor. Thanks for tuning in.
And he asks, can thoracic disc herniations cause tingling, numbness, and weakness in the thigh?
Can thoracic disc herniations cause tingling, numbness, and weakness in the thigh? The answer is yes, but it is a little bit unlikely. The most common symptoms from thoracic disc herniations are pain where the herniation is, plus both legs become weak, the whole leg, and balance problems, like you have terrible balance, and you can also lose control of your bladder and bowel, where you're peeing on yourself and pooping in your pants. So if you have a one side, you may want to get an MRI of your back and look for a herniated disc in the lumbar. Okay, we are now, by the way, send me your MRI and I'll look at it. Can you put the link mri.deukspine.com, please?
Yep.
Okay, so what we're looking at is the inside of the next disc. And this disc is going to be the L3-4. And I'm going to grab any loose fragments I can pull out. Remember, the first thing I did was I went through the foramen and pushed the herniation back through the tear. So I'm going to have to fish the herniation out from inside the disc. That's the safest way to do it. It's called the inside-out technique. It was taught to me by Dr. Young, Anthony Young. He was a proponent of it because it's safer to do it that way. There is a British surgeon who believes doing the outside-in technique, which is the opposite, obviously, and far more risky, and I don't do the outside-in, I do the inside-out. All right, any more questions from our audience?
Yes, we have a question from Rick Brookshire on Facebook.
Hello, Rick. Thanks for tuning in. By the way, all these pieces you're seeing are herniation, okay? I'm just trying to get rid of them with the grabber. Go ahead.
His question, he said, I have a question. How bad does an MRI need to look when you're making a decision on performing laser surgery? I want this laser disc repair so badly for my lower back. I'm just worried that if I get an MRI that it won't show much compared to the MRI I had 3-ish years ago when the injury was still somewhat fresh. I've been dealing with it in total for about 4 years, and it sucks limiting myself to what I can and can't do. If I move even in the slightest wrong way or sleep in the slightest wrong position, I have back pain all day and practically run to painkiller bottles. I hate taking painkillers, and I used to be very physically active person, and I literally can't work out or go jogging because of my disc problem. I'm stubborn though, so I sometimes still try to work out.
Rick, God bless you, Rick. God bless you, man. You must have started writing that at the beginning of the surgery. That was impressive. That's the longest question I've ever had. But Rick, the good news is the answer is simple. My philosophy as a surgeon, as a doctor, is I'm here to help you. So if you're having pain, I will fix it. You don't have to convince me. I do telemeds all the time, and people think they have to convince me that their symptoms are bad enough for surgery. The answer is, here's how it really should work. If you have a problem that only surgery will fix, and you want it fixed, then you should have that done. And these disc problems that you see here, these are only surgery can fix. So if your disc is the cause of your back pain, which I think it is, then I would do your surgery no matter how the MRI looks, as long as it shows me a tear in the back of your disc right where your pain is on exam. That's what I look for, okay? So you don't have to prove to me you're suffering. You don't have to prove to me you're going paralyzed. I have people tell me their doctor told them wait till they're going paralyzed before they have surgery. That's the stupidest thing. And by the way, I used to say the same thing because I didn't know any better. That's what I was told to say from my training, okay? And I went to a very good training program. But the reality is why wait? Why destroy your life and wait years of suffering when it can be fixed so easily? So send me your MRI and let me look at it. As long as you have a tear in the disc, even no matter how small the herniation is, it will be causing your symptoms. We'll fix it for you, okay? So don't worry about that part. Just decide whether or not you want to get it fixed. The answer is yes, we will fix it for you. Doctors should not be telling patients to live with their pain. That's the wrong approach, especially when it's so easy to fix the pain now. What's wrong?
No, good.
All right. Great question, and I appreciate you asking it. It takes a lot of courage to ask that question. All right, great questions today, by the way. I'm really happy to see so many people engaging us to, learn about their bodies and what can be done to fix them. I can't tell you, I encounter thousands of people that believe because they've been told by doctors or nurses that they have to live with the pain and wait till they're crippled or be in a wheelchair before they get fixed. And it's wrong. People shouldn't throw their lives away with pain when it's so easy to fix it. This, by the way, it will change. It won't always be that way. Fast forward 20 years from now, thank you, and you'll see this surgery will be done all over the world, and people will not have to live in pain anymore. All right, just cleaning up this tear, getting rid of the blue stuff, which is the herniated, degenerated nucleus pulposus. So far, everything's going well. Our patient is stable, doing good. He's asleep, comfortable. It's really nice to have patients that don't move around very much. And I'm sure Dr. Berndes is happy as well. Again, you can see the granulation tissue right there. You guys see it? That's where all the pain comes from, those little nests of cells. They're particularly visible in him, but most patients we don't see them because they're buried in scar tissue right there. You know what's in there is nerves, little bundles of nerves that are so painful. When we do the discogram, it's those nerves and those clusters that are activated causing pain. So this is all called annular debridement. It was pioneered at Deuk Spine Institute by Arias, my son, and myself. And if you go and look in the medical literature, you'll see peer-reviewed publications by neurosurgeons reviewing our surgery and, of course, approving it for publication. So
We have a couple more questions.
all right, we'll take some more questions.
This next one comes from Wanda Jones on Facebook.
Yeah, before you go any further, you guys see the pink right here? That is bone. That's the end plate of L3. All right, go ahead with Wanda Jones's question.
She asked, what is the determining factor as to which side you enter, especially if you're getting symptoms in both legs?
Hey, Wanda, thanks for asking. So the question was, how do you determine which side to go, Dr. Deuk, especially if the patient has symptoms on both legs? So what I do is I look at your MRI, and if you have a herniation on the right side, I go on the right side. If you have a herniation on the left side, I go on the left side. If you have a herniation on both sides, I go on both sides. And I can do all that virtually through a telemedicine visit. We do that all the time. As a matter of fact, I was doing telemedicine visits right before I came here to do this particular surgery. We were in the conference room. I've already met with 10 people this morning and made recommendations for their surgeries all over the internet. You can see how effective the laser is at ablating tissue, removing this pathological tissue. And again, that's the bone right there. The pink thing, it's the surface of the vertebral body at the disc. So I think all my years of playing video games made me a pretty good surgeon. That's why I think my son would do a great job too. He likes to play video games.
And we have another question.
All right, rock and roll.
This comes from Eric Fitzgerald on YouTube.
Hello, Eric. Welcome to the broadcast from Deuk Spine Institute.
And he asked, how far does the beam of the laser go past from the probe?
Great question. Yeah, so the tip of the probe right there it's glass. The beam of the laser goes out about half a millimeter, 0.5 millimeter. Look, right here. Remember, this is 1 millimeter across from one side to the other. So it goes out about half a millimeter. If you're too far away like this, it doesn't do anything. You have to come closer. So it gives me very precise control over the laser. There's a lot of misinformation out there. There are many spine surgeons who don't know how to do the surgery, and they tell their patients that the laser is dangerous. Don't believe them. They're just trying to keep you for themselves to do a fusion or some other massively invasive surgery where they make money off you. Get the best for yourself. Get a second opinion. We do a free opinion at Deuk Spine. That's a herniation right there, the blue thing. We do a free opinion through an MRI review. Just send us your MRI. Use our website, mri.deukspine.com, and we'll look at your MRI and tell you whether or not you're a candidate for the laser. All right, let's try to grab some of that. That's actually lateral in the disc, by the way. I'm looking towards me, which is to the side. Got it. Almost done with this disc, and then we'll go to our last one. All right, just about done. Yep, thank you.
We have another question.
You can actually see the epidural fat right there. This is the tear of the annulus, the white fibers. We're pretty much outside the disc right now. I'm in the foramen, so we're pretty much done. I don't see any more herniation. It's pretty much gone. Just a little bit of scar tissue here. So here you go.
All right, eye tone, please.
And the nerve will be just up there in the fat. Somebody had a question?
Yes, this comes from Wanda Jones, once again, from Facebook.
Hi, Wanda.
And she asked, so you can have a tear on the left side but still have symptoms in both legs, not just the left?
Yeah, great question, Wanda. Great question. So Wanda is saying, Dr. Deuk, what's causing leg symptoms? And why could you have a herniation on the right but get leg symptoms on the left? The answer is you cannot. There must be something on the left as well. It's just being missed by the radiologist, or it may be you have a piriformis syndrome instead. So you have a torn muscle in your butt that's irritating the sciatic nerve. So what you need, Wanda, is a real diagnosis. And again, you should send your MRI to Deuk Spine. I'm telling you, you're going to get most people get misdiagnosed out there because most doctors don't understand all the causes of leg symptoms. There are many causes of leg symptoms, and you need a good clinician to figure it out. And Deuk Spine Institute has that, but otherwise you're just going to be guessing. So let's assume everything else is totally normal, Wanda. You don't have any other problems that would cause leg symptoms, only disc herniations. Then you must have, to have left leg pain, you must have a tear or herniation on the left. To have right leg symptoms, you must have a tear or herniation on the right. What typically happens is the radiologists miss them. Radiologists miss herniations that are significant about 85% of the time. 85% of the time. So don't trust the radiologist, trust Deuk Spine Institute to read your MRI properly. All right, we're making our second incision. Seem to be okay with that. Shot. All right, you can see the guide wire inside the disc. That's where we want it. And once again, the dye is starting to dissolve away and be reabsorbed by the body and peed out. All of our patients in the recovery room, when they go pee, they actually have blue urine. Their urine is blue from the dye. It's pretty funny. I remember the first time my patient told me they had blue dye in their urine, I got really nervous. No, we're good. I'm like, why would that be? And then I remembered that the dye is processed through the kidneys. Yeah. Can you hold pressure? Shot. All right, so we're at the right L2-3. Shot. Beautiful. Let me just show the audience one more time. We're doing the entire surgery through this little, it looks like a McDonald's shake straw. That's how tiny this tube is. Shot. That's good. All right, we are in the last of the 3 discs. We've already treated 2 of them. And let's just show the audience over here the size of the incision that we did the surgery through. Can you see this?
Yep.
Everybody see that right there? 7 millimeters. Had we done a fusion on this patient, which would be another option, the incision would be this long. Right here, just like that. About 10 inches. So you can see far less trauma, no real need for postoperative pain meds like narcotics, which are bad for you and addicting, dangerous. All of it's done with anti-inflammatory and muscle relaxer. Okay, our last disc, we are inside. Any questions from our audience?
No current questions.
All right. Why don't we run the video showing people why do annular tears and herniated disc cause pain or symptoms? Watch this video carefully, folks. Even hit rewind or go to our YouTube channel. It really explains a lot about why people get back pain and why they get leg pain. The leg pain we call radiculitis. It's inflammation of the nerve root, and you'll see why people get radiculitis. The inflammation from the annular tear spreads to the nerve root right behind it, and that's what causes the leg pain. Same thing in the neck. I need the laser on.
Traumatic injury to the disc can cause annular tears to form. Pressure on the disc causes herniation of the nucleus pulpus through the annular tear. Inflammatory tissues develop within the annular tear, causing back pain. The inflamed annular tear generates pain signals. Additional injuries can cause symptoms to worsen. Inflammation from the annular tear can spread to nearby nerve roots, causing leg pain. Signals travel up nerves to the brain, causing localized back pain. Pain signals reach the primary somatosensory cortex, causing conscious awareness of pain. If you have a herniated or bulging disc and back pain, submit your MRI for a free review at www.mri.deukspine.com.
All right, folks, so this is our last disc. We're almost done. If you have questions, type them up for me and I'll answer them. But this is the tear. You see the tear right there at the base of the laser? You have the annulus fibers, and they're ripped. And that's what an annular tear looks like inside the disc. Now, the reason it doesn't heal is because it's got the blue stuff in there. The blue stuff being the nucleus pulposus. The jelly from the center of the disc blocking it. Turns out the nucleus pulposus is pro-inflammatory, meaning it makes inflammation happen. Inflammation is what causes pain. And you guys could see that on the video we just showed you. All right, so if you have questions, this is a good time to ask them. Since I'm almost done with the surgery, type them up and I'll be happy to answer them for you. Yeah, these discs have no chance of healing on their own, folks. Look at all the scar tissue here. So the body has been trying to heal this tear for years. That's what all that scar tissue, that takes years and years and years to make. That doesn't happen overnight. It takes at least, I can tell you, this scar tissue right here I'm blasting is about 5 years. So maybe his symptoms got worse in the last few years, but this problem has been going on for a long time. And that's typically the story with everybody. Everyone gets a herniation, they don't want to deal with it, they don't want to go see the doctor. They just live with it and kind of take it easy, hope that the pain goes away, and it usually does. But then it comes back because the tear is never fixed. The only way to stop it from coming back is to repair the tear. And that's what we do at Deuk Spine Institute. We're the only place in the world that repairs the annular tear.
We have a question.
Sure.
This comes from Eric Fitzgerald once more on YouTube.
Hello again, Eric.
And he asks, can you replace discs if the degeneration is that bad?
Can you replace discs if the degeneration is that bad?
Yeah.
The answer is you can, but you don't need to. The Deuk laser disc repair can treat a degenerated disc, even when the degeneration is 100% and it's bone on bone. It's not the bone on bone that causes symptoms. It's the actual tear, the tear that we're fixing right now. That's what most doctors don't know that. I would say almost all doctors don't know that. And therefore, people don't know that because they get their information from doctors usually. So what we've discovered at Deuk Spine Institute is that the tear is the source of all back pain coming from a disc. There's nothing else that causes pain but the tear. And that was discovered by my son and I, Arius, who's going to hopefully follow my footsteps someday and carry on the tradition of curing people with back and neck pain. But because there's not a lot of doctors who understand what we call the pathophysiology of back pain, you're not going to get those answers from other doctors. They may tell you to do a fusion instead. Fusion will work a lot of times because you're stopping the movement of a painful joint. And anytime you fuse a painful joint, it usually gets rid of the pain in the joint because you're no longer moving at that joint. All right, 1 minute. Any more questions?
No current questions.
Great. Well, we're going to go ahead and end the broadcast after a testimonial. Why don't you run a testimonial for people to see? And why don't you, if you have a newer one, that would be great. All right, so now you've had the surgery. How are you doing today?
I feel awesome. I mean, the only pain is, surgery site pain, and that's
Okay.
it. No nerve pain.
So the pain that you had before the surgery is
Gone.
gone, cured.
Gone. Yeah.
Awesome.
Yes, that's amazing.
I'm Dr. R. Deuk Majan with the Deuk Spine Institute, and I'm here with one of my patients who just had the Deuk laser disc repair on her lower back, and she wants to share her story with you. Now, you came to Deuk Spine Institute because you were having back and left leg pain for how long?
Well, the terrible left leg pain, probably about 2 years, but prior, I've had issues since I was 14 years old. So it's been a lot of roller coaster pain since then.
So you've had back pain since you were 14. You're clearly not 14 anymore.
No.
And so that's like 15, 20 years, right?
Yeah, too long.
And so why didn't you get it fixed sooner?
Well, the doctors when I was younger didn't want to operate. They wanted to, I was young. They didn't want to take a chance because all the surgeries then at that point, there was just nothing there that wasn't going to be traumatic to my back and my spine. So I went through physical therapy, shots, decompression. They did that and nothing was really working. And then it eventually kind of got better, and then it would get worse and it would get better, and it was just up and down, up and down.
Up and down. And the reason it got better was the inflammation from the injury to your disc started to get better.
Yeah.
But then you'd have another herniation with activity, and then it made it worse. So
Yeah.
when we were in there, and you can see from this video right here that we were pulling out lots of big fragments of disc herniation. You probably over your lifetime from 14 until now had at least 10, 20 different episodes of herniation, and that's what we saw when we were inside there.
Mm-hmm.
All right, so now you've had the surgery. How are you doing today?
I feel awesome. The only pain is, surgery site pain, and that's
Okay.
it. No nerve pain.
So the pain that you had before the surgery is
Gone.
gone, cured.
Gone. Yeah.
Awesome.
Yes, that's amazing.
Now, you're not from Florida.
No, I'm from Ohio.
So you traveled from Ohio to the Deuk Spine Institute in Florida. Why did you come all the way down to Florida?
There was nobody.
The other 499 don't. It's not bone on bone that's the problem, Beth. It never causes pain. Bone on bone does not cause pain or any symptoms at all. I have seen tens of thousands of patients with bone on bone and no pain, no symptoms whatsoever. We don't treat them. We leave them alone and they do fine. They have a normal life. It's not the bone on bone that's the cause of the symptoms. It's the annular tear that I just fixed. Even with the bone on bone, there's still an annular tear, and that is the source of pain. That's what we discovered at Deuk Spine Institute, and like I said, we published that years ago. It's just a matter of getting the word out to people so they understand. Great job, everybody. Any other questions?
No current questions.
Thank you so much for watching, and we'll be back hopefully next week with some more surgery that you can watch on our live stream. Check out our website. If you know anybody with back or neck pain, refer them for a free MRI review. It's all done virtually, so you don't even have to come here. We just do it over the internet. Have a great day.